Good afternoon. I'm Diana Erlob with Peers for Progress, and I want to welcome you to the second webinar for the National Peer Support Collaborative Learning Network entitled Peer Support in the U.S. Health Reform, Opportunities under the Affordable Care Act. The network is part of a collaborative project funded through Bristol-Myers Squibb Foundation's Together on Diabetes initiative and is co-led by Peers for Progress and the National Council of La Raza. And so before we get started, I want to quickly review the agenda. We're going to start with the presentation on the Affordable Care Act and Opportunities for Peer Support by Maggie Morgan and Amy Katzen of the Center for Health, Law, and Policy Innovation at Harvard. And following the talk, we'll have a brief overview of an issue brief entitled Opportunities for Peer Support under the Affordable Care Act by Pat Tang from Peers for Progress. Then we'll wrap things up with an interactive session led by Manuela McDonough of NCLR, where we'll open things up for discussion and give any of you who have recent experience funding peer support through the Affordable Care Act the opportunity to share with others. And throughout the webinar, unless otherwise indicated, if you have questions or comments, please feel free to type them in the question box located in the dock at the right side of your screen. And if we don't get to your question during the talk, we'll certainly follow up with you after the webinar. And within the next week, we'll post the slides and the webinar recording on our website at peersforprogress.org. And now I'd like to hand things over to Dr. Ed Fisher, Global Director of Peers for Progress.
Thank you, Diana. We're really excited by this webinar for a number of reasons. One is it's our first of year 2013, but more important, it's really exciting that we're able, through Together on Diabetes, to have colleagues like the group at the Center for Health, Law, and Policy Innovation at Harvard, Amy Katzen and Maggie Morgan, with us today. So we really have some great information to share on Affordable Care Act and opportunities within it. And we're going to have, I'm sure, a very, very productive webinar. Just to review, Peers for Progress and National Council of La Raza are delighted to be partnering in developing this National Peer Support Collaborative Learning Network. And we're really excited about the things that it's going to be doing, including the work groups on a variety of topics that many of you are involved in and that are now underway. So without much further ado, I'm going to introduce our colleague Delia Pompa, who is the Senior Vice President for Programs at National Council of La Raza, who's going to talk a little bit about some of the things that they are doing regarding Affordable Care Act. And then we'll come back and introduce Maggie and Amy from Harvard. So Delia?
Thank you, Ed. Hello, everyone. I'm not sure how many of you know about NCLR, but let me tell you a little bit about us. We are the largest Hispanic civil rights organization in the United States, and we're a multi-issue organization working in workforce development, education, health, housing, immigration, and civil rights. Our work in health is something that is extremely important to us. As you know, access to good health is something that our community has lacked for many, many years. And so we were very, very excited when the Affordable Care Act was passed, and we have, since its passage, been working to ensure that our community knows what provisions there are to support them in their seeking a healthy lifestyle, and also knows where they can go to get that support. Today, we're going to be talking about the work that we've been doing in supporting and implementing the Affordable Care Act. But before that, I'd like to also mention that the work that NCLR does in health is driven mostly by our work with promotoras. Most of the work that we have done here is delivered through promotoras, regardless of the area of health we're working in. And so when the Affordable Care Act was passed, we first thought about how our promotoras could be involved in its implementation, and most importantly, in getting the information out. As we're moving toward comprehensive immigration reform, we're also thinking ahead about how our new Americans will be able to learn about their responsibilities and their rights, we hope, under the Affordable Care Act. And so we'll be talking a little bit about that also. Since our work is driven by promotoras, we can't think of a more appropriate topic for today for you all to hear about as people who work in communities providing peer support. This topic, I think, is extremely important to all of us. Community health workers, peer supporters have a tremendous role in implementing the Affordable Care Act, and I think as a group we need to come together to figure out how we capitalize on that. So let me introduce Manuela McDonough, who is going to talk about our work so far.
Thank you, Delia, and welcome to all. So just wanted to give you a little overview of the work that we've been doing around the Affordable Care Act and how NCLR will proceed. So as you may know, 16 million eligible individuals will be enrolled for health insurance, and nearly 6 million of those Latinos will gain coverage, and this is the highest percentage of any community that will be gaining new health insurance coverage. However, successful expansion and providing coverage to these newly insured individuals is really dependent on the resources that are going to be comprehensive and actually competent to doing outreach for this vulnerable community. So since the passage of the ACA in March of 2010, NCLR has really engaged in a large array of work to advance and provide in-depth policy analysis and resources on the importance of quality, access, and affordable health care and coverage for Latinos and the ACA's impact on Latinos, particularly low-income, mixed status, and with limited English proficiency families. So we've developed several resources that are all available on our website that describe the new and improved pathways to coverage through health insurance. These are resources that are fact sheets that are easily, you can easily download and print off and are easily digestible 1 to 2 pagers that really lay out and identify a multitude of alternative coverage or care opportunities and options for immigrant families, for example. We've also been really leading some advocacy efforts on how the law will affect Latinos. So we've been sitting at some really important tables advocating for the importance of protecting and investing in funds for expansion efforts. This past March, we had our affiliate organizations come into town from over 30 states to bring this important issue to the attention of their local representatives on the Hill during our NCLR National Advocacy Day. We really are also trying to elevate the personal accounts of individuals and their families, and we're collecting stories on our website, and we really encourage you all to come and check it out at nclr.org and submit a story to share that can really capture how Latinos are engaging and how they understand the implementation of the law. And then we've also, those are just a couple of the things that we've been doing, but moving forward we're really going to take a more state-level approach and really work with our state and local officials to ensure that they're investing their energy and their resources into an effective and full investment of the ACA implementation and outreach to vulnerable Latino communities. And most importantly, our health policy team will heavily monitor and analyze ways that the ACA addresses health equity and ensure that no one is left behind when implementation is rolled out in October. So we're really looking forward to hearing more later on in the webinar on the sort of work that you all are doing on the ground, and hopefully we can talk about or figure out ways in which we can collaborate. Thank you very much.
So thank you, Manuela and Delia. Really exciting to hear about the work you all are doing. I think not only for the Latino community, but for more broadly in terms of setting models for how Affordable Care Act can be worked with to enhance health care. I want to switch now to our speakers, Amy Katzen and Maggie Morgan. Both Amy and Maggie are clinical fellows at the Center for Health Law and Policy Innovation at Harvard Law School. The center has been engaged by Bristol Myers Squibb Foundations Together on Diabetes to help with the policy aspects of the programs that Together on Diabetes is sponsoring. And they've brought a lot of energy and great experience to the activities of all of the grantees. So they're going to be talking to us today about opportunities within Affordable Care Act, especially for funding peer support programs. Let me just introduce them a little bit. Amy is working on another project she's the project lead on another project at Bristol Myers Squibb, looking at the Providing Access to Healthy Solution, or PATHS project in New Jersey. And she's also been done work on HIV/AIDS and is interested in tracking ongoing regulatory developments for the Affordable Care Act. Maggie Morgan, as I mentioned, is also a clinical fellow at the center, and she's worked a lot on national and state-based health law and policy initiatives to increase care for low-income Americans suffering from a variety of diseases, including diabetes, HIV, and other chronic conditions. So as I mentioned, both Amy and Maggie have a lot of experience to share with us, and we're delighted to have them on this webinar today. So Amy and Maggie, please take it away.
Hi, everyone. So we wanted to, let's see, can I show my screen? Yes? Excellent. Okay, I think technical success? Success, at least I hope. So as you've heard, we are going to give some information about healthcare reform and the opportunities for peer support within the Affordable Care Act. In general, as we're thinking about this, the way that we have been thinking about it anyhow is first let's understand the insurance reforms that are protecting people with chronic illness and that are about to do so even more, because many, if not all, of the patients that you all work with are likely to benefit from that. And then understand how peer supporters can help with enrollment and advocating for reimbursement in new insurance plans, both within the healthcare marketplaces and also through Medicaid expansion. Finally, we'll learn about new healthcare organizational models, including chronic health homes and accountable care organizations, and then discuss some grant opportunities in preventive services and programs. Okay, so what does the Affordable Care Act do? There are insurance reforms around making the healthcare marketplace more fair and making insurance more affordable and accessible. In addition, the ACA helps move us towards new delivery models that, at least we believe, are actually much better geared towards helping people with chronic illness. So the first set of insurance reforms that are really important is around ending discriminatory practices. So in 2014, people will no longer be denied insurance or charged higher premiums because of pre-existing conditions. In addition, already today, health plans cannot drop people from coverage when they get sick. I don't know if anyone's had that experience. I mean, I hope not, or encountered people who have. They have coverage, they've been paying their premiums, they think they're fine, and then as soon as they really need that coverage, the insurance company comes up with a reason to drop them. So that's no longer permitted. Also currently in effect, no lifetime limits on coverage. It's very important for people who have a lot of healthcare needs because, as it was before, people would run through their coverage and then be left sort of up a creek. So then in 2014, there will also be no annual limits on coverage. So that's a further protection that should be very helpful. The next major reform is around really creating a health insurance marketplace. The idea is that each state is going to have what you could think of as a central clearinghouse. It will have an online presence that will sort of be like an online storefront that we'll interact with, and it will allow individuals and employers to buy insurance coverage there. Currently, Massachusetts has something very much like that in place, the Massachusetts Health Insurance Connector Authority, which, if you Google it, you will see the kind of thing that this is going to come out to be. Very important, the federal government is providing subsidies for people with income up to 4 times the federal poverty level. FPL is federal poverty level. And what that means is that even if you're not getting your health care subsidized from your employer, the way many of us do in the course of our jobs, you can still afford insurance on the private market because the federal government is going to take over that subsidizing role that employers play for many people. The marketplaces are designed to be transparent and have streamlined enrollment. It's meant to be a very consumer-friendly experience. That should mean that a person can fill out a single application and then have the marketplace infrastructure figure out what they're eligible for in terms of subsidies and also in terms of Medicaid. Finally, there are sort of controls on what it is that insurance being sold in these marketplaces is allowed to do. So if you're selling a plan through here, it's got to be a qualified health plan, and the marketplace controls who gets in and who's out. So there are quality controls in place. And that means essential health benefits. We'll discuss what those are momentarily. And there is no discrimination based on gender or health status. Health status being if you have, for example, a pre-existing condition, they can't charge you more or put you into some kind of worse plan. Gender. Did someone just try to say something? Okay. So one thing that you may have heard, marketplaces have also been called exchanges. The two words are synonymous, but the government is moving towards saying marketplaces, so we're trying to use that language as well. Different states are choosing different ways to organize their exchange. Some, seen here in blue, are doing it themselves. They are having the exchange be organized by the state. The states you see in yellow are having the federal government operate their exchange. States in white are doing partnership exchanges, which typically means that they will keep control as a state over some part of the marketplace where the federal government will run the bulk of it. The reason that, well, a main reason that we care about who is running the exchange is that, or the marketplace, pardon me, is that the marketplace does get to make decisions about which plans get to be sold on that marketplace. Now, as I said, every single plan sold in any marketplace across the country, anywhere in the country, no matter what type of marketplace, has to include these 10 benefit categories that you see listed here. The federal regulations that are in the process of fully being determined now set a sort of floor for what each category has to include, what each of these things means, because as you can see, they're very broad categories. States can add to the requirements for their state marketplace. So for example, if you look at prescription drugs, that's an obvious area for variability. Prescription drugs on the federal side must have at least one drug in each therapeutic category or else be comparable to one of the small group employer plans in the state, whichever is greater. But a state could add in as many requirements for pharmaceuticals as it wanted. There's still going to be a fair amount of variation across qualified health plans within any marketplace in any state. Prescription drug formularies is a really obvious area of variability. So that's just something to be aware of. Peer support can have a number of different important roles within marketplaces. One obvious way is to help consumers participate in the marketplaces, and we'll discuss Navigator programs, consumer assistance programs, and in-person assistance programs. There are all ways to do that. You'll see here that there's a quick link at the top. You'll have these slides when we're done. And that's a link to the federal government's website about healthcare reform that lists the state marketplaces. So the states that are doing their own, you can link, is linked to every single one of them on that website. And we thought that might be helpful. In addition, it's a great opportunity for peer supporters to negotiate to get reimbursed by plans in the marketplaces. So that's sort of the other thing to have on your radar going forward. Now, Navigator programs, in this context, this is about helping people understand their options. It's doing outreach and public education about the marketplace coverage. You have to give fair, accurate, and impartial information. You're not selling plans. You help people sign up, and it's all about being culturally competent and accessible. These are going to be present in every marketplace, whether federal, state-run, or a partnership. In the federally facilitated and partnership marketplaces, the federal government is going to select the navigators and award grants. So this is organizations applying to the federal government. Now, the feds have not put out their request for proposals yet. We are waiting sometime in the next couple of weeks. So this is going to be done by Health and Human Services. There will be an RFP. Some of you may work for organizations that will be applying for these grants. So this could be a role that you might end up in. In partnership marketplaces, states monitor the navigators and provide support and can train them. But again, the federal government is doing the awarding of grant money. In the state marketplaces, states select navigators, award the grants, provide the training, monitoring, support. They do everything. And my understanding is that the states that are doing this have already done it. So that money, that process has already been launched. But it's still something to keep an eye on because my guess is that they will be doing more of those RFPs. I would assume they would do it on an annual basis. So that's sort of how that's working in the different types of exchange or marketplace, pardon me. In-person assistance programs are a supplement to navigators. And it's exactly what it sounds like. You are, instead of just being on the phone with someone, you're in person with them. They're not going to be present in federally facilitated marketplaces. States that are in partnerships have got to do them, and state-based marketplaces may do them but don't have to. So each state is going to make its own decision on that front. And this is another opportunity to get involved. Consumer assistance programs have been going on since before the ACA. These are programs that help consumers solve insurance problems and conduct outreach about insurance opportunities. But the ACA put a lot more money into it, $30 million in 2011, to help with appeals, collecting data on common problems, helping consumers to understand what's going on and get signed up. There's not more federal money now. Some states are continuing these on their own. It's just another thing to be aware of. Peer supporters in these categories, it seems to me that, training is available. You don't have to start out as an expert on any of this insurance stuff, but you do have to want to learn and get trained up. You all have a wonderful connection to the community and the cultural competence, in many cases language skills, that would make this a very good fit for you if you wanted to do it. You may very well work for community organizations or healthcare providers that do get grants to be navigators or in-person assisters, so this may be something that you encounter. Having now reached the slide about Medicaid expansion, it's actually Maggie's turn to talk, so here she is.
Right. Thanks, Amy. So Amy has just described for you, one, major insurance reform that really is going to expand coverage to a lot of low-income people across the country, and has also discussed the ways that peer support can play a role in that system. And so now we're going to talk about the second major insurance reform, and all of you have heard about this, and many of you know a great deal about it, and it's the Medicaid expansion. So we're going to talk a little bit about what that is, what are the main points, and then we're going to talk a little bit about some of the programs and opportunities that peer supporters may be able to take advantage of in order to get funding and kind of expand their programs. And so first, what does the Medicaid expansion do? Well, as many of you already know, it lets states expand Medicaid eligibility to adults with incomes under 138% of the federal poverty line. And so what does this mean in practice? Essentially, you can see the income limits on your screen, and this is 2013 federal poverty figures. Essentially, someone who earns the federal minimum wage of about $7.25 an hour and who works 40 hours a week, a standard work week, would qualify for this program. So it really truly represents a massive expansion of insurance for the working low-income Americans. And in addition, Amy has told you about the essential health benefits that all plans on the marketplaces have to cover. Well, any plan on the Medicaid expansion also is required to cover these essential health benefits. And there are also a few other additions that these plans will have to cover, and we'll discuss that on the next slide. And just as the marketplaces, one of the goals is to streamline the application and enrollment process. This is also the case with Medicaid. You'll have one single application for Medicaid, for the Children's Health Insurance Program, for the exchanges, and so it's essentially a one-stop shop where a consumer can go and apply for all of them at the same time. And also the Medicaid and the marketplace programs are required to work together, so it's, and to assess eligibility. So if someone comes in to the Medicaid office, applies for Medicaid, and doesn't qualify, then the Medicaid office also has to assess their eligibility for plans on the exchange and for subsidies. And another thing that's not directly part of the expansion program, but that's really interesting to note, is that the Affordable Care Act actually increases Medicaid reimbursement levels for 2 years, starting this year and continuing into next year, for primary care providers who see Medicaid patients. And they raise them to the Medicare levels because historically, as many of you know, Medicaid has provider reimbursements are lower than the reimbursements offered in Medicare. And so, in 2014, when the Medicaid expansion starts, it's going to represent a large number of people, coming into the system. And so the Act wanted to ensure that there are going to be sufficient providers who are going to care for them. And so what kind of benefits do people on the Medicaid plan get? Well, they get the 10 essential health benefits that we've already talked about. And then due to previous federal legislation, they're also required, that dealt specifically with Medicaid, they're also required to offer some additional services. And you can see most of the requirements for the Medicaid benchmark overlap with the requirements for the EHB. But there are a few additions that Medicaid beneficiaries do get, such as family planning services, non-emergency transportation, access to rural health centers and federally qualified health centers. But the main takeaway here, though, is that even though that there are these requirements that these services have to be provided in the Medicaid plans, the states have significant discretion to define these benefits themselves. And the reality is that often these benefits are probably in the expansion plans going to be defined kind of less generously than they were in the traditional Medicaid programs that serve the disabled. So what happens in a state that doesn't expand Medicaid? Well, So we've talked about, we'll talk a little bit here about the traditional Medicaid program, and generally that's restricted to specific categories of people, pregnant women, children, and in terms of adults, it's usually restricted primarily to disabled individuals and to very low-income parents who have dependent children. So those people will still qualify for traditional Medicaid. But also, people with incomes, as Amy was talking about, between 100% of the federal poverty level and 400% will qualify for financial assistance on the exchanges. But there's kind of an interesting little knot here that was unanticipated about what happens to people who have incomes under 100% of the poverty level, the very poor. Well, the Act didn't actually give them access to subsidies on the exchange because when the Affordable Care Act was drafted, the drafters assumed that this population would be covered under the Medicaid expansion. But because of the Supreme Court decision last summer, this group of individuals can no longer rely on Medicaid. It really depends on what state you live in. So in states that don't expand Medicaid, people who have incomes under 100% of the federal poverty level will actually be shut out of both Medicaid and the financial assistance under the exchanges. So this is an interesting quandary. And I know that many of you work with immigrant populations, so let's just talk a little bit about how this affects immigrants. And as you know, as a lot of you know, undocumented immigrants are not covered under any of these programs. They can't purchase plans on the exchange, and they're not eligible for Medicaid. But with legal immigrants, the situation is a little bit more complicated in that for the first 5 years, legal immigrants are not eligible for the Medicaid expansion. And because they're not eligible, the drafters of the ACA put into the bill provisions to allow all legal immigrants under a certain income level to access financial assistance on the exchange. So what happens is that legal immigrants who have incomes under 100% of the poverty level are eligible to receive subsidies on the exchange in the marketplace, to purchase private plans, while citizens in that income level are not. And so that's just an interesting thing to point out because it is becoming an issue in certain states that are currently refusing to expand Medicaid. So here's a map of where the states stand right now as of a few weeks ago. And you can see here that, the states in red are the ones that the governor has said that, they're not going to expand, while the states in blue have said that they are going to expand. And so just a word of caution here about this map. And this map represents what the governor has said. And now in some states, like in Florida, for example, the governor has come out and said that they're going to expand Medicaid, but they are getting resistance from the legislature who's refusing. So it's not set in stone yet, even when the governor comes out and expresses support. And one other thing that I wanted to note is that Arkansas has said that they're going to expand Medicaid, but they're actually doing it in a very interesting way, and it's unorthodox. And it's basically instead of actually expanding the Medicaid program, they're going to enroll Medicaid beneficiaries in the private plans on the marketplace. And they're going to receive federal funding for this. And I didn't mention this before, but I want to point out that for the first 2 years of the Medicaid expansion, the federal government is going to provide 100% of the funding for this program. And then it goes down gradually until 2020 when the federal government is paying 90% from then on. So the Arkansas approach of enrolling Medicaid beneficiaries in the private plans is something interesting that some of the other states who are resistant right now to expanding Medicaid are actually considering right now as we speak. And there's some issues with this. It may be more expensive to enroll the Medicaid beneficiaries into these plans, but some of the governors are, thinking about this idea in part because they think that it may solve some of the issues they have with getting providers on board because of the higher reimbursement rates that are likely to occur with the plans on the marketplace. So what is the role of peer support in the Medicaid expansion? And as Amy was saying, peer supporters can play an important role in helping clients enroll and referring them to enrollment assistance organizations. They can participate in the Navigator Program, which can also help people enroll in Medicaid as well as the plans on the marketplace. And there's also some opportunities to take advantage of the Medicaid expansion to advocate for increased reimbursement. For example, there are states that do reimburse for peer support in behavioral health. Now, this is in traditional Medicaid, where there is a large percentage of disabled people who are maybe receiving assertive community treatment or some other type of intensive mental health service. Well, as the plans are expanded, like in Medicaid, to a generally healthier population, states are going to have to be pushed to include some of these services in their benefit plans. And also, even in states that already reimburse for peer support, it's not guaranteed that they'll reimburse for peer support in the expansion plans, regarding behavioral health. And there's also the opportunity to push for peer reimbursement, in other services that are currently not offered, and this is going to continue whether a state expands Medicaid or not. So briefly, I want to talk to you a little bit about some of the options in Medicaid, that there are for people who are community health workers and peer supporters to maybe try to get some funding. And this applies in states with traditional Medicaid and states who do expand Medicaid. And as Medicaid is expanded, we're going to see so many more people in the system and more dollars in the system. And so I think it's worthwhile to consider some of these options. And I know that Pat Tang in the issue brief has addressed some of these as well, so you'll want to take a look at that. So first, there's Medicaid administrative funds as an option. Well, the Affordable Care Act requires states to establish outreach procedures to vulnerable populations, and there's a list of vulnerable populations that are included, from racial minorities to homeless youth. But in order to do this, in the Medicaid programs, administrative funds are provided by the federal government to the state, and the state also contributes. And these are separate from the actual medical services that are provided. And some of these services include things like outreach, eligibility determination, coordination, and translation. These are things that Navigator is going to be doing, but these are also things that can be funded by the state, who contracts with public health departments and community groups who do these kind of outreach services. And so community health workers and peer supporters should take a look at their state Medicaid plans and see what's covered here, and they possibly can partner with public health departments and other groups to kind of provide some of these outreach services that are going to be required by the ACA. And one interesting thing that I do want to point out that peer supporters should be aware of is that even though a lot of the outreach efforts are going to be dedicated towards getting people enrolled in the expansion, there are still a lot of people who aren't enrolled, who are eligible for traditional Medicaid, who are disabled, but who aren't enrolled right now. And so when you're enrolling people and when you're reaching out to people to enroll them in the expansion, you want to make sure that the person is also not eligible for traditional Medicaid, because often the services in the traditional Medicaid are going to be more comprehensive and they would be better suited there. But there's some concern that states may try to push some people into the expansion plans because they're getting more federal funding for these than they will with traditional Medicaid. Another option is Medicaid managed care organizations. The problem that we have often is that, in the fee-for-service traditional Medicaid, peer supporters are not reimbursable providers. But with managed care, the way that they're paid is through capitation, through like a single payment. And once they meet certain requirements, then they're able to have more freedom to, figure out how to spend the money to provide services. So in this way, there's a good opportunity for peer supporters to be reimbursed by the MCOs. And some states have already done this, and I know in Pat's issue brief there's some examples of of how this may have, happened. And one other way to kind of reach beyond the restrictions that Medicaid has for peer supporters is to implement a waiver, a Section 1115 waiver in Medicaid. These basically let states apply to change federal rules, and that kind of currently restrict populations from being part of Medicaid or restrict services. And so if you apply for a waiver to treat peer supporters and community health workers as reimbursable providers, you can get around the initial restrictions. And some states have already done this as well. And this is an opportunity for all state Medicaid programs to consider. And one problem though is that it's a bit burdensome. It requires the state to show that this is going to be cost neutral for the federal government, and they're not going to spend more money with the waiver on their Medicaid program than they would have without it. Okay. And just to clarify, the MCO is the managed care organization. All right, so we've discussed a little bit about what role peer supporters can play in the Medicaid expansion. And so another major innovation of the ACA is to change the model for healthcare delivery. There are a lot of, there's quite a few provisions that are aiming to create a system of coordinated, integrated care. And to do this, there are several options, and we're going to discuss a few of them now. Chronic health homes, long-term supports and services, and then Amy's going to discuss accountable care organizations and emphasis on prevention. And so the current fee-for-service system kind of often leads to fragmentation across many providers. There's often the tendency not to pay for care coordination and case management, and sometimes there's insufficient cultural competence in health navigation. So this system basically is not ideal for chronic disease management. And so one thing that the ACA tries to do is to implement a provision called the chronic health homes in the Medicaid programs. And they're trying to incentivize states to provide more coordinated chronic care. And before we go into the specific elements of what the health home is, let's talk a little bit about how it was formulated in the first place. Well, many of you do work in patient-centered medical home models already. And this is kind of the basis and the foundation for the creation of the health home model. And it's basically the patient-centered medical home is focused on creating a coordinated, integrated system of whole person care, where different teams of healthcare providers work together to make sure that the patient is receiving holistic care. There's a focus on having a flexible scheduling system and easy access to members of the team. And then there's a focus on reforming payments to push it more towards the quality-based payment system that rewards providers for showing results. And so what does the ACA do specifically? Well, they give states the option in their Medicaid programs to implement health homes for individuals with chronic conditions. And so this is completely separate from the expansion. Any state can do it regardless of whether they expand their Medicaid program to non-disabled adults or not. And they're hoping, with this provision and the implementation of these health homes to improve care for people with chronic conditions and also restrain growth in Medicaid costs by kind of holistically treating the whole person and trying to make sure that no one falls through the cracks in any way. So who's eligible for a health home? Well, it's Medicaid beneficiaries who have 2 or more chronic conditions, or who have 1 chronic condition and are at risk for a second condition. And there's also a third category, and this is one for people who have 1 serious and persistent mental health condition. And this shows the emphasis of the ACA and the health home option on behavioral health. Because studies have shown that people with chronic conditions are more likely to develop behavioral health issues, and then when people who do have both chronic conditions and behavioral health issues or more likely to have difficulty managing their condition. And so the chronic conditions listed in the ACA are 6 conditions, and these are mental health, substance abuse, asthma, diabetes, heart disease, and being overweight. But these are not exclusive. A state doesn't have to just restrict their health homes to these specific conditions. They can actually go beyond this or choose not to cover all of these conditions, and we'll discuss that in just a minute. But what kind of services are in a health home? I mean, it sounds like it's the actual physical location, it's a home, but that's not actually the case. It's really just, the health home is a system of care coordination and management across providers and across systems. And the services that are provided include, comprehensive care management and coordination, which, basically means that the ideal definition of this that states are encouraged to adopt is basically, setting up a comprehensive treatment plan that responds to the patient's specific needs across all areas of care, and then ensuring that the patient is connected to these providers and that the providers are communicating with each other and that the care plan is being adhered to. And also on the list of required services under the health home option is health promotion. Now this includes preventive services, education services that relate to chronic disease, such as diabetes self-management, obesity counseling, tobacco cessation. There's also a focus within the health home option on transitional care. So people who are discharged from the hospital are a particularly high-risk group, and they can fall through the cracks sometimes of the system if their care is not being coordinated, and then they can end up being readmitted to the hospital, and that's a very expensive proposition as well, not to mention the effects on chronic illness. And so there are services in the health homes to provide follow-up care and coordination for people leaving the hospital and making sure that they're getting access to all the care they need. And finally, there's a strong emphasis on community services with health homes. Health homes are really about integrating medical care with community care and getting it all together in one comprehensive system. And so for patient and family support, health homes are required to link patients with chronic illnesses to peer support, to support groups, to peer specialists. They're required to give them access to housing services, legal services in their area, public benefit services. And so it's a very broad set of coordination services here. Now, how does a state apply for a health home? Well, they have to submit a state plan amendment, to amend their Medicaid plans. And 8 states, as of last month, have had their plans approved by the federal government, but there are several more who are awaiting approval right now, and then there are others who have applied for a planning grant to examine the feasibility of a health home. And it's interesting to note here that a state can submit more than one health home. Actually, they can submit an unlimited number of health homes. For example, Missouri and Rhode Island have submitted 2 that treat different populations. Like one can be like mental illness, and the other can be other, physical illnesses, or one can be for children, and another can be for adults. So there's a lot of variation here. And as I had just kind of indicated, states have considerable flexibility to design their own health homes. They can determine their own populations. They don't have to restrict themselves to the conditions listed in the Act, though most states have chosen to cover all of those conditions. They can just cover mental illness if they want to, or they can cover an expansive number of conditions. North Carolina covers 10 different conditions. Oregon includes people with, hepatitis C and HIV and cancer. And also, a health home plan can be restricted to people with a certain acuity level of illness. You could restrict it to people with more severe cases of cancer, of diabetes. And you can also restrict it to specific geographic areas. Most states haven't chosen to do this, but One thing that New York did was initially implement a 10-county health home and then expand it statewide. And you can receive funding for different geographic areas. So if you expand it in one area, you can get the funding, and then if you expand it in another area, you can get funding. And we'll talk about the funding in just a second. But there's also a significant opportunity for flexibility in providers, and this is where peer support can come in. You can see here there's a list of 3 categories, and these are the 3 categories in the ACA of providers. But the big takeaway here is that there's a lot of flexibility in who can be a provider in a health home. You can see the term other provider here. Peer supporters can certainly play a role in these teams and work alongside medical professionals here. One important thing to note is that health homes don't have to be based in a primary care facility or practice. Now, a person in a health home obviously has to have access to primary care physicians, but you can base the health home in a community mental health center. You can even base the health home in a non-medical setting, such as a supportive housing facility that works closely with a certain patient population that you're trying to target and has good access to providers and to resources. So this is an important point. And what are the financial benefits to states of adopting the Medicaid health home option? I mean, it seems like a substantial undertaking to do, but for the first 2 years, the federal government is going to give states a 90% federal matching funds for their health home services program. So after 2 years, the match rate reverts back to the state's normal Medicaid rate. But for the first 2 years, the enhanced funding will allow the program to get set up with the hope that in the future there'll be cost savings that will be realized. Now, it's important to note that the enhanced match doesn't apply to the underlying Medicaid services that are provided to individuals in the health home. So if there's a peer supporter working with a homeless person, I'll just speed up just a little bit so we don't run out of time. But if you're working with a homeless person and you're referring, and they get cancer, and you refer them for cancer treatment, the enhanced match doesn't apply to any of the cancer treatment. It just applies essentially to the coordination services. And the payment methodologies, usually, and there's a lot of variance in how a state can do it. They can do a monthly management. That's the most common, is the capitated monthly management care fee. And states really have a lot of leeway here to tie these payments and to vary these payments based on quality indicators. So if a provider is, treating people with a more severe condition, they can get enhanced funding. If they have more advanced patient-centered medical home capabilities, and such as like electronic, health record systems, or even they're able to provide, community health workers to go out into the community and link people up more effectively, they could potentially be eligible for more payments. And so if you're maybe a little confused about the differences between medical homes and health homes, like patient-centered medical homes and health homes, they're very similar, but there's just a few differences in the Medicaid program, and I'll just point out briefly. The health homes are required to coordinate with behavioral health providers, as I mentioned. They're required to help enrollees obtain non-medical supports and services, and they don't have to be based in a primary care setting. And I've already talked about how peer support can play a role in these care teams, and it can be a way to kind of get around the restrictions in the current, fee-for-service Medicaid program in most states. You can, even if a state, doesn't cover peer support directly, a peer supporter can, receive some reimbursement by playing a role in some of these health homes for people with chronic conditions. I also briefly want to point out a potential opportunity in the ACA. It's unfunded right now, but it's for community health teams for patient-centered medical homes, and maybe there will be funding one day. And so it's basically trying to encourage primary care physicians to set up patient-centered medical homes. And if they don't necessarily have the resources, they want to use community health teams of, multidisciplinary support players and providers to come in and work with the primary care physician to provide community services such as outreach, prevention, and education. Now, even though it's not funded by the ACA right now, some states are starting to look into the possibility of doing their own programs with these, with community health teams, and look at the example of Vermont's Blueprint for Medical Homes to see a good example of this. They're using state Medicaid funds and also private insurer funds to send out community health teams of, community health workers out into the communities and working with these primary care physicians. So I'm just going to briefly touch upon another area that the ACA is trying to reform delivery systems that may have opportunities for community health workers. And this is long-term supports and services. Right now, state Medicaid programs have to pay for nursing home care and institutional care, but they're not required to provide long-term services outside of the nursing home, like home and community-based services. So the ACA is encouraging states to experiment to move away from institutional care towards community and home support services. And one reason for this is because they're less expensive, and also people do have the right to choose to live in home and community settings. And I'm not going to go through all of these programs. I'm going to leave the slides here and make them available so that you can go back and look at them if you're interested in a particular program. But these Medicaid programs provide enhanced funding if states will, add more home and community-based services. And essentially, the opportunities for peer support in this system are significant in the long term because a lot of the long-term supports and services involve outreach, going out into communities, enrolling people who are in need of long-term support services, making sure that people who are discharged from nursing homes and are moving into their houses are still getting the care they need. And even though a lot of these services in the past and currently haven't reimbursed for peer supporters, there is one program that I wanted to point out that has been promising in Arkansas, where the Medicaid program is funding community health workers to go out into the community and work specifically with long-term support populations, to go out to their doors to reach them, to enroll them, and to follow up with them to make sure they're getting the care they need. And so this is a potential opportunity for a state Medicaid program to integrate peer supporters. And I think, and I have some more slides with some other community-based organizations opportunities that are possible here that you could look at. And I'm going to turn this over to Amy to discuss a few more things that represent innovative delivery systems, including accountable care organizations.
So this creates a sort of challenging acronym situation because we've got the ACA and now we've got ACOs, but I trust that you will bear with me. Accountable care organizations are made up of healthcare providers across the continuum of care. That means that you are likely to have hospitals, primary care, a series of specialties. You could even have a nursing home or that type of provider included that agrees to be held accountable for improving the health of its patients. That is to say, they get a certain amount of money typically, and if the healthcare costs end up being less than what they'd otherwise be expected to be, they get to keep a share of that savings. ACOs predated the ACA, but the ACA really starts promoting the model heavily. Medicare is a really great opportunity for the government to change the way that healthcare runs because it's a really big player in the market. So Medicare has a shared savings program. ACOs are eligible to participate. It basically is exactly what I just said, that if you end up spending less than normally would be expected to be spent for the population you're covering, then you get to keep part of what you save. Pioneer ACOs have that, but they also have downside risk. They're pioneers because they're risk-taking, so they could actually lose money on the deal. the ACA creates a 5-year demonstration project for Medicaid pediatric ACOs. That's a relatively small part of the whole ACO universe, but states are also launching Medicaid ACOs just on their own without any particular Affordable Care Act impetus that are going to cover, the whole Medicaid population, or anyone in Medicaid is eligible for them. Now, the ACA is silent about ACOs in the private market, but insurers are pretty interested in it. And so Aetna and United Healthcare are both exploring options. They're not alone. It's a model that you should look to see becoming increasingly common over time, particularly if it goes well. So states are, as I said, working on Medicaid ACOs. Colorado has one working. New Jersey is almost there. Oklahoma, Oregon, Utah, Massachusetts, and Vermont are all planning Medicaid ACOs, and my guess is that that list will grow over time. Now, why do we care about this in particular from a peer support perspective? Well, provider organizations have an incentive to reduce costs, but they can't do that by just skimping on care. That's not allowed. You've got to actually, there's a whole set of protections about, as a provider, you can't solve the problem by just not giving services to people. That's not how you're supposed to save money. Well, how are you supposed to save money? You're supposed to actually do a better job. And peer supporters are really well positioned to help do that, to be members of care teams, to be employed by provider groups. Because if you're getting, in particular, some kind of global payment or fixed amount, per member per month, it makes sense to use some of that resource to, especially for people who tend to be more expensive patients, where they have chronic diseases, where they are struggling to participate in their care, to reach out and help people. That's going to be cost effective. And I know that you folks have done some really excellent research showing how it's cost effective. So it really fits together with the whole ACO concept really nicely. Now, I know that peer support on the behavioral health side within states, there are training and certification programs that you all have developed with states in order to get reimbursed for behavioral health programs on the Medicaid side. You might consider taking that idea and really expanding it for other chronic disease programs, because that's going to help with promoting the use of peer support in the ACOs. It's going to help sort of raise the sort of professional perspective about it from provider organizations. Just a thought. And relatedly, other thoughts about getting involved in insurance plans. ACOs are not insurance plans, but it's the same intuition. It's getting yourself into a sustainable payment situation, whether it be a salary as part of an ACO or getting reimbursed on a fee-for-service basis. Quantitative and qualitative data collection is a big deal. I know you all know this and you're working on it. Using that data to argue for cost effectiveness and how it makes sense to get into the marketplace, get into Medicaid, get into Medicare, and that ongoing professionalization on the training side is going to be really helpful, because insurance plans like to see that everyone has some kind of certification. The other thing that the Affordable Care Act really starts to do, and they mostly do it through the cunning use of money, is really changing to an emphasis on prevention. So on one side, Medicare and new private plans have got to cover routine preventive services that are judged to be cost effective, graded A and B by the USPSTF. That's, gosh, the U.S. Preventive Services Task Force. And no cost to the consumer. That is no more cost sharing. So certain benefits, there's another slide about them, you've got to get without cost sharing. In addition, that's available under Medicaid for if states in their Medicaid plans also make these same preventive services free of cost sharing, they're going to get a bump in their federal reimbursement. So the Federal Match Assistance Program, that's not what that acronym is, assistance percentage, increase for their Medicaid. So essentially, the federal government is trying to get states to be generous in this way without mandating that they do so. What are these services? Well, here is a list. You can see that it's really geared towards helping people to understand what they're at risk for and then getting counseling around improving those issues. So tobacco use, obesity and diet and diabetes issues are all really important here. In addition, there are investments in prevention. This is where the real money is. Here we have many links. So the Prevention and Public Health Fund is where most of this is running through. And the first link, and again, you're going to get these slides, which is why the links are helpful, there's a really nice map at Health and Human Services that you can click on a state and see exactly what's happening there. So that's, we thought that might be the most helpful thing because it's too much to go through out loud for either you or us. And then here are a few examples below that about particular types of grants that are out there. Many of these are happening right now. So these aren't things that you can go out and apply for this minute because the grants have been distributed, but it's worth seeing who in your state and in your region got them and thinking about participating in some way with those organizations either now or down the line. Community transformation grants, I think, are particularly exciting because they've got this focus about, controlling high blood pressure and cholesterol, tobacco-free living, active living, and healthy eating. These are all areas that I think peer supporters are really well positioned to coach people on. And not only states and local governments, but also community-based organizations can participate. Now, there are a number of grants that are appropriations-based. That is to say, the ACA didn't give any money for them. They just authorized that they should exist. And then it's a question of whether Congress appropriates money. Congress hasn't for all of them, but they are out there. So it's something to just be aware that, particularly if we can get out of the federal budget mess, there could be new money coming in for some of these things. And I just want to flag the patient navigator grants there, the last bullet. This is confusing because we just talked about navigator grants in the context of the marketplaces. This is a different thing. This is maybe something you're more familiar with, actually. This is helping people actually navigate their healthcare system, and often, it would be helping people make appointments and figure out what doctors they need to see and figuring out transportation to get to the doctor and that sort of thing. These grants were first authorized in 2005 and then were reauthorized in 2010 under the ACA. And they're running through 2015. I'm hoping that they're going to be reauthorized again in 2015. So that's not something that wasn't funded. It's just another thing that I'm hoping is going to recur after 2015. We have reached the end, you may be thrilled to know. So to recap, the main points of the ACA: more people will have health insurance and you can help them sign up, which is a nice thing to do and also might mean you get reimbursed. Speaking of reimbursement, this is the perfect time to advocate for peer support reimbursement in Medicaid and in private insurance marketplace situations because everything is in flux and it's the time to get in there. Relatedly, new healthcare models are going to really benefit from peer supporters, so it's a great time to work on partnering with health homes and ACOs. Finally, there's federal money for preventive care. A lot of it is not something you can get into right this minute, but it's something to really keep an eye on, and like I said, click on that map and see who by you is already working on some of these things that you can maybe work with them on. So here are our email addresses. We will very much look forward to hearing from you with any questions that you may have that we haven't managed to address with all of these many words. And I think we can answer some questions now. I believe that is true.
So maybe as you tell people, let's type in their questions.
Oh, right. If you type in your questions, that makes sense. If you type in your questions, then I can answer them. maybe no one has questions. Maybe you're all just completely clear on everything, or alternatively, completely overwhelmed, in which case, sorry about that. But you have our emails.
Well, thank you very much, Amy and Maggie. That was hugely informative and comprehensive. I think we all could develop a 5-year plan out of what you presented.
I think
Diana, did you want to take over again and guide us through the rest of the program?
Sure. I did see that they have a question that just came in. Maggie and Amy, if you guys want to answer that question aloud, or if you want to type in your response, I'm not sure how you want to handle that.
Oh, I can definitely, I think I can answer it, or try to. So the question, someone has 1 point and 1 question. First, that Maine is entertaining legislation for Medicaid expansion, which is very exciting. And second, how do you convince providers and payers to think outside the box on reimbursement? I think that there are a couple of things. One is the more research that you have, and I know that this is something that you're working on because I've seen some of it, to say this is something that actually works. And it works both in the sense that people feel better and are healthier, and in the sense that because they're feeling better and are healthier, some of the most expensive types of health care are going to go down. You're not going to see people in the emergency department as often when they're utilizing other forms of care that are cheaper. So there's sort of a, I mean, frankly, I guess you would say it's a business case, and it's rooted in data as opposed to just saying it's intuition. And I think this really is a moment when a lot of people are starting to think, what do we need to do to get in on this sort of health home ACO type model? And this is so people are, I think, actually in this frame of mind. Maggie, do you have anything to add?
I mean, I would say also one point to emphasize for resistant states is that their citizens are going to be using their tax dollars to pay for care in other states. And if they don't implement care for their own citizens, I mean, that's a pretty, difficult thing to have to deal with, where you have states, down the road from you where, the federal tax dollars of all citizens are being used to pay for their care, and then that care is being denied to your own citizens just because of what state you live in.
Right. Medicaid expansion should really happen. For a whole variety of reasons. I hope that's helpful.
Thanks, Maggie and Amy. We're going to go ahead and move on to Pat Tang, and he's going to do a quick overview of the issue brief. I do see we had a couple of more comments and questions that came in, so maybe you guys can take those and type in the answers and share that with everyone. But I'll go ahead and hand things over to Pat.
So yeah, just going to spend a couple of minutes to talk about the issue brief that Peers for Progress put together recently. We put together this last November and have been updating it with new information. And as you could tell from the presentation today, there's just so much information out there about the Affordable Care Act. It's hard to know what opportunities are out there. So we thought it'd be great to just find a way to put out all the opportunities for peer support in a short 5 to 6 page document, and this is what we came up with. So the entire first page here, if you'll follow along, is just some background on community health workers, the definition in the Act. There's a link to the actual document itself if you want to go and refer to that. And then we break down some of the opportunities into 3 categories. So on this page we have reimbursable routine services. So that includes chronic health homes that were talked about, the community health teams, patient navigator programs, Medicaid incentives. And if you look on the right-hand side, We'll either have an example of a program, some more resources to find out more information in the blue boxes. For the boxes that are in tan, those are for programs that are currently unappropriated. They've been approved, but Congress hasn't appropriated those. So this is an easy way to see which ones are available and which ones aren't. The second category is capacity building, development, and training. So this would be to promote the community health workforce, community health center funds, cultural competency programs, and something that we are very interested in is the small business grants. And the third category is the research and demonstration grants. I think both of these were mentioned in the presentation. I don't remember if the Medicare readmission reduction program was, but that's something that's come up recently as well. And please, if anything is not up to date or you have any suggestions, we want this to be a working document, a living document, where people can tell us how to improve and give us suggestions on it. On this page, there are several states that have state-applied initiatives that include community health workers, incorporating it into their reimbursable services, into their routines, and highlights a few examples. They're in different stages of their integration. And on this page, this is the most recent addition to the brief, is some more information on these chronic health homes. And I think a lot of this information was covered in the presentation, but this is all on one page for you. And yeah, that's about it for the brief. If you have any questions or comments, please use the link at the bottom to email me, and I'd love to hear back from you.
Well, Manuela, if you want, we could open it up to just more general Q&A, and if people want to ask any of the presenters any questions, you could raise your hand, or you can type in your question if you're having trouble with the hand-raising feature, and we can just use the remaining time to have any additional Q&A that people may have.
That's a great idea. Thanks.
The question from Mike is, not all consumers that he talks with are enthusiastic about federally funding peer services. There's a fear that the organic aspects of peer support will be lost with the advent of federal funding. And I guess I agree that there are trade-offs whenever you are trying to take something that is organic and extremely flexible and put any kind of I don't even want to say restriction, but any kind of set of rules around it or regulations around it. So I think one question, and this is not something that I know the answer to, but I suspect that you folks do, in the states where Medicaid is funding peer support in the behavioral health context, there is absolutely training and certification requirements that are involved. And the question is, has that, in your experience, created any kind of any harm? Has it reduced? Has it created barriers to entry that are a problem? Has it taken some of the soul out of it? Because if not, then I wouldn't worry about anything else doing so. I think that the question you have to think about is, you're getting my stream of consciousness. This is not happening to you, it's happening with you, right? Peer supporters are only going to get involved in this stuff to the extent that you want to be involved. So you can make it the way you want it to be, or at least very much the way that you want it to be. And I think that you can't both have the sustainability of having your services be reimbursable and also sort of be flying solo, if that makes sense. And I think I mean, it's not for me to say. If it were me, then I'd probably be cool with that trade-off. But that's because I'm really big on stability. I assume people vary in that. I don't know if that's... Mike wants to write back with any kind of follow-up. Maggie might have more coherent thoughts.
I mean, there's definitely, I think, a tension, as everyone, I'm sure you're all, much more aware of this than we are, but there's a tension between, when you're, looking to the Medicaid program to get reimbursed, there's going to have to be some certification requirements there and some standardization. But, I mean, I guess the issue would be at a practical level, figuring out how you can, accept some certification while kind of, fighting to keep the particular elements of it at a certain level so that the organic nature of it and the relatively, maybe perhaps informal relationships between the peer supporters and the patients can remain, and that it doesn't just get caught up in the bureaucracy. And I think that that's a fight that could, be successful at a certain level, and I think that one way that would be effective in trying to get reimbursement while maintaining as minimal certification requirements as possible would be to look to case studies of what has happened. Maybe looking at the Arkansas program where they trained 6 community health workers who weren't were people with the same education levels as the communities they're working in. They send them out to work one-on-one, but looking at those and seeing what level of training they received, what certification requirements they received, and looking at the results and maybe doing a comparison across different programs and seeing, making the case that you don't necessarily need, a really high level of certification in order to have a successful program. I mean, that would be my best guess as to how to kind of address that tension.
Yeah, and I guess as Maggie was talking, I remembered, the community health workers are increasingly sort of getting formally integrated, and I think it's been okay. I mean, that's a very general statement, but that's been my impression. It seems very positive from what I've heard on the CHW side. And let's see.
So,
I know that,
go ahead.
No.
I didn't want to interrupt. I was just going to mention that we're at 4:30 now.
Yeah.
I don't see any hands raised. I think you either verbally answered or typed in answers to the questions that have come in so far. So we probably want to go ahead and close. But I did want to mention that we'll plan on, in addition to the slides and the webinar recording, we'll plan to put a document of the Q&A, a summary of the Q&A, the questions and the answers also up with our other materials on our website with the slides and the recording. So we'll make that available as well. Is there anything else, Maggie and Amy, that you'd like to say before we close?
Just thank you.
Yeah, thanks for having us. It was wonderful and really exciting to talk to you all about these things.
Thank you. We really appreciate your presentation. It was really great. Thank you so much. Ed and Delia, Manuela, do you guys want to say anything?
I just want to add our thanks.
Just thank you. It was a great presentation.
Go ahead, Delia.
I wanted to thank all the participants for hanging in there. I do think this information is important to all of us, and I hope we can go back and make good use of it.
Thank you. Thanks, Ed. Did you have anything else?
Just to agree, and again, thanks for the presentations, and as Delia mentioned, thanks for the participants for hanging in there.
Okay.